Okay, I am supposed to introduce the next speaker, Kalani Raphael, who is the faculty at the Division of Neurology and Hypertension, University of Utah. Whenever I do not know something, I always go to Kalani because he's a younger generation who knows not only computers and iPhone, he knows everything. And Kalani also has been doing a lot of good research on bicarbonate in metabolic acidosis and patients with CKD. And he is going to try to talk to you today about electrolyte disturbance. I did not use any trade names.
Okay. Is that okay? Can you hear me? All right. So I'm giving you a very practical talk today on several electrolyte disorders that are commonly seen both in the clinic but mostly in the hospital. So this is kind of, more of a hospital issue or emergency department issue, but some of these do pertain as well to the clinic. So the objectives today are to go over disorders of sodium, potassium, bicarbonate, and I'm going to give you a bonus case, which I think is really cool. Something's wrong with the slides. We're not getting the top part here. Do you know any jokes, Dr. Chung? You're full of them. No? Not ad-lib? I can go through them, I think. We'll give them a few seconds. There we go. Perfect. All right. So those are our objectives. Okay? This is very case-based, so hopefully it'll engage you in some thinking and as to what you might do if you saw these patients. So the first case is a great case, a 24-year-old woman who had generalized weakness. We were called by the internal medicine team because her potassium was undetectable and her bicarb was low. Her urine pH was high. They thought she had an RTA. They said, "Can you see her? Thanks a lot." So here is her exam. Blood pressure 115/52, heart rate 79. She was generally weak, and she was very hypotonic on physical exam. Here are her labs. Most notably, you can see that her serum potassium is less than 1.6, so indeed it was undetectable. And you can also notice that her bicarb was low, 16. So there are really three problems here when you look at her chemistry panel. Number one, obviously, is the profound hypokalemia. The second is a low bicarb. And if you calculate the anion gap, meaning take the sodium concentration, take the sum of the chloride and the bicarb and calculate the difference, the anion gap was normal. It was 13. Okay? So those are the three problems we're dealing with here. All right. So the question we're going to ask ourselves is, do you agree with their diagnosis that this is an RTA, renal tubular acidosis? All right. So there are her labs. Okay? Just to show you some other labs, she had a blood gas because of that low bicarb. Her pH was 7.41, PCO2 was 29, PO2 was normal, bicarb on the calculated blood gas was a little bit higher at 18, and the base excess was -5. So, do you agree? Is there an acid-base problem, even though the pH is normal? And the answer to that question is yes. Even though that the pH is normal, if you have any abnormality of either bicarbonate or CO2, you do have an acid-base abnormality. So what problem would it most likely be? Most likely it's a metabolic acidosis. Even though the patient's pH is normal, a lot of times what happens is when you come and you threaten the patient with an arterial stick, they tend to hyperventilate, and so their pH might rise up into the normal range. So it was presumed that this patient indeed had a metabolic acidosis with a normal anion gap. Other labs, just to show you, calcium was normal, phosphate was low end of normal, magnesium and thyroid tests were all normal as well. So back to our two main problems, profound hypokalemia, and we now consider her to have a normal anion gap metabolic acidosis. Okay, so we're going to first talk about what to do with this hypokalemia. So in general, any disorder of potassium really can be thought of in three big categories. First is kidneys are losing it. Second is you're losing it from the GI tract, or you have redistribution. In terms of renal loss, obviously diuretics are probably the most common cause of hypokalemia. You can also have renal tubular acidosis types 1 and 2. Anything that promotes aldosterone activity, such as vomiting. Okay, this is actually the mechanism by which vomiting leads to hypokalemia. It's not loss of potassium from the upper GI tract, it's through induction of aldosterone. Similarly, hypovolemia stimulates renin, angiotensin, and aldosterone, and also primary hyperaldosterone. All those things promote hypokalemia. Also, high urine flow rates, which can be induced by diuretics as well, but in other conditions such as diabetes insipidus, you can have hypokalemia, and anything that increases sodium delivery to the distal nephron. So that's kind of a general list of items that cause renal loss of potassium. In terms of GI loss, it's really diarrhea. That's about it. But when you think about redistribution, it's really thinking about what are those treatments that we typically give to patients who have hyperkalemia, right? So if you give a patient insulin when they're hyperkalemic, the way that it lowers potassium is by redistribution of potassium. So those things are insulin, when you give somebody a beta agonist, such as with albuterol inhalers. Anything that raises blood pH and promotes alkalemia can cause hypokalemia. Hyperthyroidism, alpha blockers, and exercise can also promote hypokalemia by redistribution. And what I mean by redistribution is shifting potassium into the cells where the concentration is higher than in the extracellular compartment. So the diagnostic approach to any case of hypokalemia that is not entirely clear is really to separate things out into two broad categories. Is it a renal problem where the kidneys are losing potassium, or is it a non-renal problem such as GI loss or redistribution? Okay? So just to go back, we do have this test that we commonly get called a fractional excretion of sodium. It tells us what the kidney is doing with sodium, right? This is not related to potassium, but just to illustrate some similarities between the tests I'm going to tell you about next. The way that we do the FENA is we order a urine sodium and a urine creatinine. We divide the sodium by the creatinine, and we do the same with the blood creatinine and sodium levels. Okay? And if the FENA is less than 1% in the setting of acute renal failure, it tells us that there is high levels of renal sodium retention, pre-renal acute kidney injury. Or if the FENA is greater than 2%, it suggests that there is high renal sodium loss, which is more consistent with ATN. Okay? So now the question is there a fractional excretion of potassium? And the answer to that question is yes. Transtubular potassium gradient. Have any of you heard of this? Heard of this test? Okay, great. So the transtubular potassium gradient is very similar to a fractional excretion of sodium. It tells you what the kidney is doing with potassium in the setting of hypokalemia. And it also works in hyperkalemia. Okay, so the test is very similar to the fractional excretion of sodium in terms of the calculation. To do a TTKG, you just order urine potassium and a urine osmolality, and you get a serum potassium and serum osmolality at the same time. And that formula, again, is very similar to this fractional excretion of sodium. You take the urinary things and divide it by the serum things, just like you do with the FENA. Okay? So why do we use osmolality in this case? Why not use creatinine? It really is because of potential urinary concentration. So if the urine is very concentrated, that would make the urine potassium concentration very high, which might suggest that there is increased renal potassium loss when in fact there may not really be that. And it corrects for the difference in osmolality between the urine and the serum. Okay? So this is why we use the serum osm and the urine osm and not the creatinine values in this test. Okay? So when to get a TTKG in hypokalemia? A lot of times, you know that the patient's on diuretics. That's really why they have the hypokalemia. But if you're not sure and you cannot readily identify the cause of hypokalemia in a patient, check the TTKG. The tests that you order really are serum chemistry and an osmolality, and order urine electrolytes and urine osmolality. And again, it reflects what the collecting duct is doing with potassium, just like the FENA. The FENA tells us what is the kidney doing with sodium. The TTKG tells us what the kidney is doing with potassium. And it helps us to distinguish these two different broad categories of hypokalemia, renal versus non-renal. Okay? So you do this, you have this patient, you have a low potassium, you're not sure what's going on, you order a TTKG. So what does that tell you? Okay? Well, the cutoffs that you're using are kind of obscure, but in general, the result of your TTKG will send you into one of these two categories, renal potassium loss or non-renal potassium loss. And so if you have a high excretion of potassium, meaning more than 7%, that is not what you want the kidneys to do, right? You want the kidneys to hold on to potassium and not excrete so much. So if you have a high percent excretion of potassium, that tells you that the kidneys are the reason why you're losing potassium, okay? If you have a low excretion of potassium as calculated with this TTKG, meaning less than 3%, that tells you that the kidneys are doing the right thing, they're holding on to potassium, and they're trying to restore the body's total potassium stores. This tells you that you have non-renal potassium loss, such as from GI losses or from redistribution. Okay? So back to our patient. We order the TTKG. These are the values we get. I don't expect you to do the math here, but the results are low. Okay? The TTKG is 2.3%, which is low. Okay? So that sends us over into this category here, right? The TTKG is less than 3%. It tells us that the cause of the hypokalemia is not due to the kidneys. You with me so far? Okay. All right. So there are two other hints here. Anytime you get a spot urine potassium, anything less than 20 would suggest that there is actually renal retention in the setting of hypokalemia. And just to confirm this, a 24-hour urine potassium was done, and it was very low at 17 milliequivalents. This was done on another day, okay? So all of this evidence supported the diagnosis of a non-renal cause of potassium loss, all right? So all of this evidence, again, supported non-renal potassium loss, okay? So our next problem to deal with is the normal anion gap metabolic acidosis, all right? So metabolic acidosis can really be broken up into two big categories, a normal anion gap and a high anion gap. There are really three main causes of a normal anion gap metabolic acidosis: an RTA, loss of bicarbonate from the GI tract, or iatrogenic, giving sodium chloride in the hospital. And with these conditions, you have a gain of chloride and an equal loss of bicarbonate from the serum. Now, in terms of high anion gap, we all have heard of mud piles, I presume. We'll talk about that a little bit, and I'll show you some other interesting cases about high anion gap metabolic acidosis, but I'm going to leave that for now, okay? So what do we do with this patient who has a normal anion gap metabolic acidosis? Again, the patient had a low bicarb, and we suspected that she had metabolic acidosis based on her blood gas. All right. So again, we're looking at, is this a kidney problem or is it a non-kidney problem? This is really the two main ways that you want to think about a normal anion gap metabolic acidosis. And in terms of a renal cause, the only cause is one of the broad categories of renal tubular acidoses, or a non-renal cause, such as, again, GI loss of bicarbonate or sodium chloride infusion. Okay? So the question to ask yourself is, what should the kidneys do when there is too much acid, and how do the kidneys do that? So in terms of the basics, this is, back to medical school type things, but I just want to point out a couple of things about how the kidneys get rid of acid. In general, urinary acid excretion is determined by these three variables: urinary ammonium excretion, excretion of titratable acids such as phosphates, uric acid, even creatinine in some degree is an acid, as well as how much bicarbonate is reabsorbed, okay? But the primary means by which kidneys adapt to an increased acid load, this is a slide I copy from a lecture I give to the students, is tended to get them to think about what is the primary means by which acid is excreted by the kidney, and the answer to that question is by increasing excretion of ammonium. Most of these other things, including titratable acids, don't really actually change. But the main thing to think about here is that you want to know what the kidney is doing in terms of ammonium production and excretion, because that's the key thing that the kidneys should upregulate in the setting of acidosis, okay? So if there is metabolic acidosis and the kidneys work normally, right, the kidneys should be trying to get rid of acid, and the kidneys should be making tons of ammonium. Okay? Lots of ammonium if the kidneys are working well. All right? And that ammonium will bind to chloride in the urine. So a urinary chloride in the setting of this situation, a normal anion gap metabolic acidosis, estimates the urinary ammonium concentration, which estimates if the kidney is responding appropriately to the acid load that it's bearing. All right? So the test that you want to order in this case is urine electrolytes, which includes a sodium, potassium, and a chloride. And what do you do with this? You calculate the urinary anion gap, which is the sum of the sodium and potassium minus the chloride in the urine. So back to this. Kidney etiology, renal tubular acidosis. If the kidneys are the cause of the normal anion gap metabolic acidosis, the kidneys aren't making much ammonium, it's not binding to chloride, you have low urinary chloride in comparison to sodium and potassium, and your urinary anion gap is positive, okay? So an RTA, urinary anion gap as determined by sodium, potassium, and chloride is positive. If the kidneys are working fine, if your acidosis is due to loss of bicarb from diarrhea or sodium chloride infusion, okay? If your kidneys are working fine, kidneys are not the cause of the anion gap acidosis. It should be making tons of ammonium, which binds to chloride, so you should have lots of chloride in the urine, and the amount of chloride in the urine will exceed the sum of the sodium and the potassium. And in this case, your urinary anion gap is negative. All right. So here are the two main categories of normal anion gap metabolic acidosis: renal cause or a non-renal cause. In this case, the test you want to get is a urinary anion gap or electrolytes and calculate the difference between the positives and the negatives. If the urinary anion gap is more positive, this tells you that you're dealing with a renal etiology of the anion gap acidosis and you're dealing with an RTA. If the urinary anion gap is negative, it tells you it's not the kidney's fault, okay? You're losing it from the GI tract or sodium chloride infusion. All right, so back to our case. Okay, so we've worked out the hypokalemia. Now we're going to deal with the anion gap acidosis. We ordered the urinary electrolytes, sodium and potassium and chloride. You calculate the anion gap, which is the sum of the sodium and the potassium, the two positive charges, which is 59. Compare it to the chloride, and there is more chloride in the urine than these two combined, and you have a negative urinary anion gap, which tells you that the kidneys are working fine. And it's a non-renal cause of the acidosis, okay? So in this case, the medicine team called us and thought that she had an RTA. And we wanted to, and the question I asked you is, do you agree with this diagnosis? So what do you think? Is it an RTA? Is it hypokalemic periodic paralysis? Or is it laxative abuse and diarrhea? Diarrhea, right, good. Because we've proven that the kidney is trying to hold on to as much potassium, and we've proven that the kidney is doing the right thing by getting rid of as much acid as possible, okay? So they got the diagnosis wrong. All right. Okay, so what do you do in this case? Very important. Correct potassium first, right? This patient was hypotonic. The serum potassium is undetectable. And if you were to correct the acidosis first, it's also important to remember that acidosis raises serum potassium, right? So if this patient had a mild acidosis, you would expect her potassium to be higher than it actually is, but it's already undetectable. If you were to correct her acidosis with sodium bicarbonate first, you would drive down potassium lower and you could eventually possibly kill her, okay? So the idea here is whenever you have a major problem with hypokalemia, always correct potassium first, just like you do in DKA management, and then you correct the acidosis with sodium bicarbonate either intravenously or orally. Okay, all right. So to summarize, okay, we've talked about normal anion gap acidosis as well as potassium. So in cases of a normal anion gap metabolic acidosis, the main test to get is a urinary electrolytes and calculate the urinary anion gap. Positive urinary anion gap tells you it's the kidney's problem. Negative tells you it's not, okay? And in terms of hypokalemia, again, if you're not sure of the cause of low potassium, check this test, the TTKG, orders serum and urine chemistries as well as an osmolality. Anything less than 3% means that the kidney is holding on to potassium, which you want it to do. If the percent excretion is 7% or more, it's telling you that the kidneys are excreting potassium inappropriately. Now the TTKG, this is a new concept, I think, to most of you, but it's also useful in settings of hyperkalemia. Now, in this case, you want to know what is the kidney doing with potassium. If potassium is high, what do you think the kidney should do in the normal setting? It should get rid of it, right? So your percent excretion of potassium should be high. And in this case, the cutoff we use is a little bit different. It's 10%. And this is the appropriate response, and it tells you that the kidney is not the problem. However, in the setting of hyperkalemia, high potassium, if the TTKG is less than 7%, it's telling you that the kidney is not doing the right thing. It's holding on to potassium too much, and therefore it is the kidney's fault. That's why the patient has hyperkalemia, okay? So here, the percentages that we use are a little bit different than in the setting of hypokalemia. 7% tells you, or lower, tells you that it's inappropriate renal potassium retention, or if it's 10% or more, then it tells you that the kidney is doing the right thing, okay? Again, hyperkalemia can really be thought in three broad categories: reduced renal excretion, such as obviously due to renal failure; obstruction, such as from BPH, or bilateral kidney stones for some reason; hypoaldosteronism type 4, which is also known as type 4 RTA. Non-steroidals can do it as well as potassium-sparing diuretics. Now, in terms of GI gain, not too many things, but upper GI bleeds can actually cause significant hyperkalemia, okay? And then finally, redistribution. These are things that we're all familiar with that can promote hyperkalemia, such as low serum pH, too low of an insulin dose on patients who have hyperglycemia, beta blockers, rhabdomyolysis, tumor lysis syndrome, interesting disorders such as pseudohyperkalemia and alpha agonists. Okay, so I'm done with potassium. We're going to move on to the next one, dealing primarily with sodium here. So case number 2. We have a 54-year-old patient who has a sodium of 120. What 3 tests do you order to determine the etiology of hyponatremia? So let you think about that for a sec. Any thoughts? Urine sodium, good. All right, so serum osmolality, urine osmolality, and urine sodium. Now, our house staff always know to get these tests, but they're always a little confused as to what to do with them, okay? So here are the results for this patient. And I'm going to go through a stepwise approach to how do you look at these tests to help you make the correct diagnosis in such a patient, okay? So in this patient, the serum osmolality was 260, urine osmolality 600, and a urine sodium was 40, all right? Hyponatremia, defined as a low serum sodium, in this case, it's 120. Really, you have 3 broad causes. Hypoosmolar, defined as a serum osm less than 280. Isoosmolar, defined as a serum osmolality within the normal range. Or hyperosmolar, defined as an osmolality greater than 300. Okay? In terms of hyperosmolar, there aren't that many things that cause this. Glucose, mannitol, or infusions of hyperosmolar sucrose or mannitol, which is commonly used in IVIG. Similarly, isoosmolar hyponatremia, there aren't too many causes. Sorbitol and glycine can cause this. This is commonly observed in patients who've had transurethral resection of the prostate surgery. But more commonly, I think, talked about is high lipids and proteins, which is also known as pseudohyponatremia. But really, the most common cause of hyponatremia is hypoosmolar, or the most common category of hyponatremia is hypoosmolar hyponatremia. Okay? So what do you do with these darn tests that you ordered? Okay? First thing to do, look at the serum osmolality. If your serum osmolality is high, you're dealing with hyperglycemia, or mannitol. Mannitol most likely used in neurointensive care units. So a lot of times, we pretty much know why the patient is hyponatremic if they are on mannitol. If the serum osmolality is normal, think of lipids and proteins. If it's low, you're thinking of everything else, okay? So in this case, our serum osmolality was 260, all right? So that basically rules out hyperosmolar, right? We're not dealing with hyperglycemia or sucrose or mannitol. Rules out isoosmolar, and we're really focusing here now on hypoosmolar hyponatremia, okay? So if you have hypoosmolar hyponatremia, meaning you have a low serum sodium and a low serum osmolality, the next thing to look at is the urine osmolality, okay? If you have a urine osmolality that's very low, meaning that it's very dilute urine, you're really dealing with a state in which ADH activity has been turned off, which is what you would see in patients who have polydipsia, right? If you ingest a massive amount of water and you dilute down your sodium, you want your kidneys to get rid of that water, and you would turn off ADH, and your urine osmolality would be very low because you are inducing a water diuresis, okay? So polydipsia is one of the causes of that, as well as something called beer potomania, or anything that promotes low solute intake, okay? However, if your urine osmolality is more than your serum osmolality, it tells you that ADH is active, and it's either an appropriate ADH response or an inappropriate ADH response. So how do we determine the difference? Well, if you have an appropriate ADH response, okay, which you might see in settings of low blood pressure, shock, sepsis, or in hyperosmolality, okay? In this case, I'm going to tell you about low effective arterial blood volume, okay? The ADH that is secreted is appropriate in response to low effective arterial blood volume. What happens is when you secrete ADH, it tells the kidney to insert these aquaporin channels into the collecting duct. Aquaporin channels then promote the movement of water back into the blood, okay? But if you are dealing with a patient who has sepsis, physiology, heart failure, they have low effective arterial blood volume. They're also stimulating aldosterone, which goes to the kidney, inserts sodium channels into the collecting duct, and promotes sodium reabsorption as well, okay? So in these cases, patients who have low effective arterial blood volume, why do they get hyponatremic if you have both salt and water reabsorption? It's really an imbalance of how much water is reabsorbed in comparison to sodium. In this case, when you have hyponatremia, you have excess renal water reabsorption in compared to sodium, and so that further dilutes down your serum sodium concentration, leading to the hyponatremia. So in these cases, because you have high aldosterone activity, you have high sodium reabsorption, your urine sodium is very low. It's usually less than 10%. And your urine osm is greater than the plasma, okay? Now in the SIADH, which is where people get hung up quite a bit, it's important to remember that these patients are not hypovolemic, they are also not hyperosmolar, but they're secreting ADH inappropriately. And it does the same thing. It tells the kidney to insert aquaporin channels into the collecting duct with movement of water into the blood. It leads to a high urine osmolality, as would expected, and the urine sodium is usually high, okay? And so the hallmark features in this scenario are hyponatremia, a high urine sodium, which is usually more than 20, and a urine osmolality that's greater than plasma. All right. So back to our patient, okay? We've ruled out hyperosmolar hyponatremia. We are now in this category of hypoosmolar hyponatremia. We looked at the urine osmolality. It was 600, which was not low, obviously, so we've ruled out beer potomania and polydipsia. Now we need to determine if this ADH response is active appropriate or inappropriate. So the third step is to look at the urine sodium, okay? If the urine sodium is less than 10, this is telling you that the patient has aldosterone activity and you're dealing with a state that promotes low effective arterial blood volume, such as sepsis, shock, etc., okay? If your urine sodium is more than 20, bingo, you've got SIADH, okay? So back to our patient. Step one, these are the labs, here. Serum osmos 260, okay? Look at the serum osmolality, categorize it. We are down here, hypoosmolar. Step 2, look at the urine osmolality. Is it less than 100? No, so it's not polydipsia, okay? Step 3, look at the urine sodium. Is it less than 10? That tells, if it were, you would be dealing with a state of low effective arterial blood volume. If it's more than 20, SIADH. So where does this patient fit? SIADH. Yep, okay, good. All right, but always interpret urine sodium and consider diuretic use as well as sodium intake in these patients. So this is a general approach to the evaluation of the cause of hyponatremia, which I think is something that's very challenging for people and causes a lot of confusion. So hopefully this has helped a little bit. All right, in terms of the management of hyponatremia, I don't want to spend too much time, but I just want to point out that I don't get too excited unless the patient is severely symptomatic. And by severely symptomatic, I mean seizure, I mean coma, I mean they are in bad shape, okay? And you must also really think that their symptoms are due to hyponatremia, in which case the sodiums are usually less than 120. If it's 125 and they're not doing so well, I'm not so sure that those symptoms aren't from something else. So you have to really be sure that those symptoms are due to the hyponatremia, okay? So what should you do? If you have somebody who's severely symptomatic, seizure, coma, low sodium, I give patients a bolus of 100 milliliters of 3% saline, give it every 10 minutes, and give them up to 3 doses. Each bolus will raise the sodium by about 2 milliequivalents per liter, and the reason why you do the bolus is to rapidly reduce cerebral edema and improve these symptoms of seizure and coma. Obviously, this doesn't mean that you don't need to monitor sodium. Obviously, you do, and you should continue to do that. In terms of other general treatment principles, most people would say that if you have a serum sodium that's less than 120, you would want to increase that serum sodium back to about 120 at a correction rate of 1 milliequivalent per hour. After that, you can slow down your correction rate to about half a milliequivalent per hour once you've hit 120. Now, what fluid? It really depends on the volume status. If you have a patient who is hypotensive or volume depleted, you would want to use normal saline to restore that blood volume and turn off the ADH, turn off the aldosterone. If the patient is relatively euvolemic, such as in an SIADH patient, you'd want to go ahead and use 3% saline. Okay? What about diuretics? Obviously, you can use diuretics in patients who have the cardiorenal syndrome or in cirrhotics. In people who have SIADH, you can also use fluid restriction, which works mildly to moderately well, or you can use salt tabs. One of the main problems with salt tabs is we're not giving enough of a dose. Usually we give 500 to 1,000 milligrams 3 times a day. A lot of times people need to have much higher doses, like 6 or 7 grams per day of sodium chloride. Okay? New interest in the use of Vaptans, like tolvaptan, which is the only one that's approved in the US. That's the only approved oral Vaptan that I'm aware of. There's Conivaptan, which is intravenously used and obviously can only be given in the hospital unless you have a patient who has peripheral access. But Vaptans are used in the treatment of hyponatremia. But I just want to talk a little bit about urea as well. Okay? Urea was used back in the day to manage hyponatremia. Some of you may use it. Dr. Chung, did you use urea? You're not that old? Okay. Dr. Chung is apparently not that old. Okay, but urea has also been used, all right? So this was a very interesting study that I found from C. Jason, published about 2 years ago, around the time that Vaptans became, something that was talked about quite commonly for the treatment of hyponatremia. In this study, it's a small study, 13 patients. They all had hyponatremia to start, so they're at 125. For the first year, okay, they got a Vaptan. Don't remember which one it was. It was in Belgium. I think it was Satavaptan was the most commonly used one. But anyway, the 13 patients got various types of Vaptans. And what happened was the serum sodium went up quickly, okay, 135. After 1 year, they stopped the Vaptan for 8 days. Rechecked their sodium, came back down. Then they gave them urea powder, 15 to 30 grams diluted in orange juice. And what happened? Serum sodium went back up. So urea is much, much cheaper than a Vaptan and is equally effective. The problem is you can't find it here. Okay? Urea would be a very great treatment, I think, for people who could handle the bitter taste. You may need to dilute it in orange juice. And the other problem with Vaptans as well is that there are reports and concerns about liver toxicity. So actually, the warning says that you cannot use tolvaptan for more than 30 days. So the long-term benefits of Vaptans like tolvaptan may not exceed the risks. Okay? So hopefully, we may be able to find some urea for these patients because I think we're finding more and more now that low serum sodium is a problem for people. Causes bone loss, increases the risk of falls and fractures, cognitive dysfunction. So we may need to be a little bit more aggressive with the treatment of chronic hyponatremia. Okay? So just a little blast to the past with urea. All right. So pitfalls in correcting hyponatremia. Number one is correcting too quickly, which I think we all know about with the central pontine myelinolysis. Aggressive treatment in people who aren't severely symptomatic, okay? And forgetting to include potassium replacement in correction formulas. Why do I say this? Because it can lead to overcorrection of your serum sodium. How does that happen? Well, if you have a patient who has a low serum sodium, okay, and you give them intravenous sodium, okay? What does that do to the cell? It actually shrinks down the cell, right? It's pulling fluid back out of the cell, and it's raising your serum potassium concentration inside the cell. However, if you have a patient who is hypokalemic, they still have very low total body potassium. Now what happens if you give them potassium? All that potassium is going back into the cell to restore the intracellular potassium. And in order to maintain electrical neutrality within the cell, you're kicking out a sodium. And that sodium can directly raise your serum sodium, and you can overcorrect too quickly. So always think about serum potassium levels and add the serum potassium to your formulas for correcting sodium concentration. Okay? So that is another pitfall in the correction of hyponatremia. And then finally, if you decide that you want to try to correct a patient with hyponatremia with normal saline and you see that their hyponatremia worsens, you're probably dealing with SIADH. Okay? In SIADH, if you give a patient normal saline, it can actually worsen their hyponatremia. Okay? So be careful in patients you suspect have SIADH. Don't use normal saline. Okay. All right, third case, quickly. Serum sodium of 155. Okay, hypernatremic. What one test do you need to do to identify the cause of the hypernatremia? And the answer is simple. Just one test, urine osmolality. Okay? So the normal response of the kidney in the setting of hypernatremia is, because there is hyperosmolality, is to secrete ADH. Again, ADH will go to the kidney, cause water reabsorption. That water reabsorption will dilute down the hypernatremia and correct the sodium. Okay? So if ADH is secreted and the kidney is responding to it appropriately, okay, you should have a high urine osmolality, holding on to all that water to try to bring down the sodium, and by doing that, you concentrate the urine. Okay? So again, is it a kidney problem or is it not a kidney problem? If you have hypernatremia, two broad categories. You either have loss of water by the kidney or you have loss of water from another source, such as the GI tract, the skin, or in the lungs, which is common in patients who are on the ventilator in the ICU. Okay? All right. So what do you do with this urine osmolality? Again, you have to think about what should the kidney do. Okay? If the urine osmolality is more than the serum osmolality, it tells you that ADH is working, right? It's being stimulated from the brain, it's going to the kidney, it's binding to the receptor, it's inserting water channels, and you're holding onto water. Holding onto the water will dilute down the sodium as much as it can, and by doing so, it concentrates the urine. Now, by far, this is the most common thing, okay? If you observe that the urine osmolality is higher than the serum osmolality, it tells you the kidneys are doing the right thing, and it's something else. Either you're losing water from the skin, such as in burn patients, the GI tract, such as in people who have diarrhea, or from the respiratory system, like in patients who are on the ventilator. or it can also be from excessive sodium intake, such as normal saline in the hospital, okay? If your urine osmolality is lower than your serum osmolality, it tells you that ADH activity is impaired. Either it's not being released by the brain, or if it is being released by the brain, the kidney is not responding to it. And that is a disease that's called diabetes insipidus. If it's a release from the brain problem, it's central. If it's a problem with the kidney not responding to it, it's called nephrogenic DI, or diabetes insipidus, okay? Now, if you have a hypernatremic patient, in which case the urine osmolality is equal to the serum, think of diuretics, all right? But really, when you're looking at a patient with hypernatremia and you're not really sure what's going on, the one test that you want to get is the urine osmolality to rule out this condition, diabetes insipidus, all right? So this is just the flow of how you would approach this, hypernatremia. If the urine osmolality is too low, it tells you that the kidney is not responding to ADH. If the urine osmolality is high, it tells you the kidney is doing the right thing, okay? So we order a urine osmolality and it's 900. Does this patient have diabetes insipidus? The answer to that question is obviously no, right? Patient's holding on to water, concentrating the urine. So the patient does not have DI, okay? All right. So I'm done with potassium, I'm done with sodium. This is a really fun case, okay? This is case number 4, a 40-year-old male who was seen in the clinic after pancreatitis, okay? He was in the hospital for quite some time. Came in, said he was improving, but he had poor appetite, he was tired, he had some abdominal pain, okay? He is a chronically ill guy. Congenital nephrogenic diabetes insipidus is what NDI is. He also has familial polycythemia, gout, RA, obstructive uropathy, and recurrent bouts of pancreatitis. He's on a bunch of meds, probenecid, amiloride, and HCTZ, doxazosin, nitrofurantoin, finasteride, colchicine, methotrexate, acetaminophen, potassium, and a vitamin. On exam, he's afebrile, blood pressure lying is 118/72, heart rate's 114. Stand him up, blood pressure falls a little bit, heart rate goes down a little bit, JVP is 2 centimeters below the sternal angle, and he has some edema. Here are his labs. Okay, so what jumps out at you? Bicarb's terribly low, right? So sodium's 141, potassium's 3.3, chloride's 103, bicarb is 9. Normal would be about 24. BUN's 29, creatinine 1.7. We notice this low bicarbonate. We calculate his anion gap, and his anion gap is high, 29, okay? So the basic differential diagnosis of an anion gap metabolic acidosis, which is what we're going to talk about right now, includes these things: methanol, uremia, DKA, peraldehyde, INH, lactic acidosis, ethylene glycol, and salicylates. Okay, that's the basic diagnosis. So the tests that commonly get ordered to work this up are serum osmolality, which will help you detect methanol and ethylene glycol. Check the urine for ketones. Check the blood for lactic acid, and then do a tox screen to look for salicylates. Okay? So back to our case. We suspected that the patient had a metabolic acidosis. We confirmed it with a blood gas. The pH was low. The anion gap, again, was high. And so these are the labs that were done on this patient. The serum osmolality was 307. To detect methanol or ethylene glycol, you have to calculate the serum osmolality, which has been done for you here, and look at the difference between the the measured osmolality as well as the calculated. And here the difference is only 9. Okay? If you have ethylene glycol poisoning or methanol poisoning, usually that difference in the osmolality is at least 20. Okay? So here we've ruled out methanol and ethylene glycol. Lactate was normal, ketones were undetectable, there was no alcohol, toxic alcohols were negative as well, which means the patient was actually tested for ethylene glycol and methanol despite these normal, difference between serum and calculated osmolality. Tylenol level was 38, salicylates were negative. So all these tests were normal, right? Not really helpful. But the one thing we have here is acetaminophen. So how might acetaminophen explain this? Well, acetaminophen is metabolized in 3 different major pathways. First, it's glucuronidated, about 50%. Some of it is sulfated, about 25%. But some of it gets metabolized to cysteine and mercaptopuric acid conjugates. But in this pathway, you get depletion of glutathione, right? This is why you get liver toxicity from the NAPK that forms in this metabolic pathway, okay? So depletion of glutathione seems to possibly be something that is important here. So what is glutathione? Glutathione is part of this pathway called the gamma glutamyl cycle, which is important or most notable for the GGT test that is looked at for liver injury. Okay, so glutathione is part of this pathway, okay, that basically gets recycled here. All right, number of different things. I don't expect you to remember all this stuff. Okay, but when you have depletion of glutathione, it can cause some problems. All right. Just for some background, glutathione by itself inhibits this enzyme here called gamma glutamyl cysteine synthetase, okay, which allows this reaction to occur. All right? So now, this is important because when you have acetaminophen and you have glutathione depletion, since you do not have any more glutathione, you don't have this G-glutamyl cysteine synthetase, okay, inhibition. It's not inhibited anymore. All right? So you have activation and increase of the gamma-glutamyl cysteine, but you cannot form glutathione. This actually goes through this other pathway, which leads to this thing here called 5-oxyproline, which is also known as pyroglutamic acid, and that builds up in the body, okay? So pyroglutamic acid is one possibility here. So in the urine, you can actually measure pyroglutamic acid levels, which is also known as 5-oxyproline. A normal level is less than 70. And in this patient, the values were more than 40,000, okay? So very high levels, all right? But it's not just Tylenol. Sorry, is that vitamin T? Not just acetaminophen, okay? You can also have buildup of this pyroglutamic acid, which would cause a high anion gap metabolic acidosis. There are inherited disorders in which you have a disorder of this enzyme and that enzyme. Things like sepsis can deplete glutathione, as well as pregnancy can deplete glycine, which can eventually lead to the buildup of this pyroglutamic acid or 5-oxyproline, okay? So this is kind of a cool case, but it really kind of makes you think about some of the other causes of a high anion gap metabolic acidosis. In this case, the treatment is largely supportive, okay? Stop the acetaminophen, and usually you have to look for something else going on, like sepsis or an MI or pancreatitis, as it turned out to be in this patient again, all right? Hemodialysis can be used. It's been used in case reports largely to correct the acidosis, and NAC is theoretically beneficial, but it hasn't been studied, okay? So I told you about mud piles. If there's one thing that maybe you learned today, it's this other mnemonic called cute dimples, okay? It's another mnemonic for a high anion gap metabolic acidosis, okay? And here you go, okay, a lot of things. And it really, I think, is important because you may miss some of these causes if you don't look for a high anion gap metabolic acidosis or it looks elusive to you. So here's a differential for cute dimples, cyanide or citrate, okay? Citrate is commonly used in dialysis, in continuous dialysis therapy in the hospital. Obviously, uremia is here. Toluene, which is in glue and paint, and commonly, you get toluene toxicity in people who sniff glue, which is kind of fun to Google on the internet. People who have, and look at their pictures, you see like paint all over their face, and they have toluene toxicity. Ethylene glycol, DKA, isoniazid, and iron. Methanol is still here. The P includes the pyroglutamic acid. Propylene glycol can also cause a high anion gap acidosis. This is most commonly seen in the ICU. The propylene glycol is in the diluent that is used for Ativan. Okay, so a lot of patients who are on long-term Ativan in the ICU can have propylene glycol toxicity, which leads to a high anion gap acidosis. Peraldehyde is also here as well. Peraldehyde is not available in the U.S. Lactic acid, I always remind people that there are both the D and the L types of lactic acidosis. Okay, so in patients with short gut syndrome, they may be more likely to develop the D type of lactic acidosis, which can be elusive. Ethanol ketoacidosis, and finally, salicylate starvation and sodium thiosulfate, which is something we use for dialysis patients. Okay, last case, and then we'll be done. So the ER called, and they said that they had a 29-year-old Hispanic woman who came to the ER with burning pain in her feet. They were about to send her home, but then her labs came back, right? This is a common story. And what you notice here is the chloride, yeah, 139, okay? So what did they do? They said, repeat the labs. Good thing to do, right? You also want to double check to make sure that this is still accurate. So the chloride was still high, 139. And if you calculate the anion gap, it's actually negative, which is not, terribly feasible with life, at least in the amount of negativity that you would observe here, okay? So you have a hyperchloremia and a negative anion gap. They said, whoa, the anion gap is off here, let's get a blood gas. Blood gas was stone cold normal, normal pH, normal CO2, normal bicarb, no acid-base abnormality, all right? Patient was admitted to the hospital, underwent an extensive workup. All these tests were normal. CBC, LFT, FOS, MAG, all these heavy metals, all these other antibodies, TSH, hexosaminidase A, pregnancy test, blah, blah, blah. Everything was normal, okay? Here's a hint, though. 3 years later, she had a spastic diplegia, distal neuropathic pain, and sensory loss, and she was walking with a stiff-legged antalgic gait using a clawed cane, okay? So we have these three problems, a hyperchloremia, a negative anion gap, and irreversible neurotoxicity, okay? Anyone have an idea what the diagnosis might be? Okay, bromism. People ever use bromide back in the day? No? Common treatment in the olden days, probably 30, 40 years ago. Dr. Chung, are you that old? You're not that old? Okay, so bromism, okay? Bromism is the diagnosis here, okay? And it's kind of funny. It's actually in Mountain Dew, okay? Brominated vegetable oil. And there are case reports of kids who are up all night playing video games and consuming massive amounts of Mountain Dew. And they come into the hospital, abdominal pain, they don't feel well, and they have bromide toxicity from Mountain Dew, okay? Another problem that can happen is you can get something called bromoderma, which is a very interesting rash. This was from a patient in the New England Journal of Medicine where they got this sort of bromoderma lesion, and this was due to ruby red squirt, okay? So not only is fructose bad in these drinks, but the bromide can be bad for you as well, all right? So one of our more astute colleagues, this was before I was there, I'm not sure I would have got this diagnosis, but measured a serum bromide level, and it was very high, 170 milligrams per deciliter. If you convert it to millimoles per liter, it was 21. Measured the chloride by a chlorometer, and it was actually normal, okay? So why? Well, it's actually that when you send this sample to the lab actually mistakes the bromide for chloride because they're so close in the periodic chart. Bromide is right below chlorine, and so, bromine is right below chlorine, and so it's really a problem with the machine detecting bromide as chloride, okay? So when you measure the chloride by the chlorometer, it's actually normal, okay? And so that's why the chloride was 139. So what is bromide? What is it used for? Well, it was used as an anticonvulsant as well as a sedative back in, I think, the 50s and the 60s. It substitutes for chloride in the nerves and kidneys and can lead to irreversible neurotoxicity, okay? So levels of 10 to 50 are, okay for sedation. If it's been used for seizure control, levels of 75 to 150 are acceptable. And if you have more than 150 milligrams per deciliter, you can observe debilitating neurotoxicity. And our patient had 170 milligrams, and this is exactly what ended up happening to her. Levels in the blood more than 300 may actually be fatal. So where did it come from? This is where the history was important. She was from Mexico. She was in the US for 3 years. She did not drink, no tobacco, no drugs. She said she took this herbal supplement called maca. She also works in a furniture factory where she glues styrofoam chair seats, but she doesn't use personal protective equipment. And she also mentioned that another worker started walking funny. Okay? So what is maca? Maca is this root from a plant that is used for a number of things, but actually there is some bromide in there, about 1 to 2 milligrams per capsule. I don't recall how much she was taking, but it was thought that maybe this was why she had bromide toxicity. But the problem was there were other people who had some problems, right, with the walking. So the question was, is this an occupational exposure? And it was determined that 1-bromopropane was a solvent that was used in the glue. And remember, she wasn't using personal protective equipment. Okay? 1-bromopropane is a solvent which was introduced about, I want to say 12 years ago to replace chlorofluorocarbons, or CFCs. And if you remember, CFCs were banned because these deplete the ozone layer. Okay, so this is why 1-bromopropane was introduced into the glue here. Okay, but 1-bromopropane is also a carcinogen. Okay, so we've gotten rid of the CFCs because they deplete the ozone layer, but it's now been recognized that 1-bromopropane is actually a carcinogen, and it could lead to bromide toxicity in some patients. Okay, and don't worry, it's used in your dry cleaning, so you're fine. Okay. They actually went back and tested other workers, and they also confirmed that these patients had elevated bromide levels as well. So I thought that was a pretty cool case. All right, so in summary, we've gone through a lot here, and hopefully you just take home a few key things, that you can use something called the transtubular potassium gradient to evaluate tricky cases of potassium disorders. Hopefully I've made it a little bit easier for you to approach disorders of low sodium as well as high sodium. We've gone over the urinary anion gap for normal anion gap metabolic acidosis. And then finally, I hope that I've taught you something in terms of cute dimples and thinking of other things that might cause a high anion gap metabolic acidosis. And I just want to thank the Ogden Surgical Medical Society for inviting me to speak, as well as the NKF of Utah and Idaho. Thank you.